This is the 6th video in a series talking about myths of urinary tract infection taught in medical school. This one is pretty ubiquitous, and I'll attempt to answer the question, what are the treatment outcomes associated with antibiotics for symptomatic bacteriuria and urinary tract infection? Am I avoiding ascending infection like pyelonephritis by giving someone antibiotics? Again, to start with defining terms, I would consider a quote-unquote complicated UTI as being some sign of infection outside the urinary bladder. This is upper tract disease. We used to consider complicated UTI as symptomatic bacteriuria in patients who were at risk for ascending infection, but that led to unnecessarily long antibiotic courses. Most patients that are at risk for ascending infection improve with short courses of antibiotics and are also at risk for harboring drug-resistant organisms. So overtreatment of bacteriuria in this group has some serious consequences if they actually do get sick. Lack of treatment options, if they eventually ascend, can be life-threatening if you miss. Most of the data with UTI comes from simple cystitis studies in young females, and I think there is an argument, to be fair, that we don't have a lot of strong evidence for shorter course antibiotics in this very specific and vulnerable group. But instead of being forced to give long courses, it might make more sense to tailor your treatment duration to a patient's clinical improvement. If they're really stable, improved, and symptom-free, do you really need more antibiotics? I don't think so. The fear of development of pyelonephritis influences a lot of antibiotic prescriptions for bacteriuria, especially in populations at risk for ascending infection. My patient is special. I don't want them to get worse. Even though I know they are asymptomatic, they can't sustain any sort of decompensation. So I'm going to treat just in case. But do antibiotics for bacteriuria actually prevent pyelonephritis? Almost all studies say no. In a meta-analysis from 2009 looking at placebo-controlled trials, there was no difference between the antibiotic group and the placebo group in the incidence of kidney infection, but, as you would expect, those treated with antibiotics had more adverse effects reported. I thought this randomized control trial from NEJM was fun. 6 weeks of antibiotics, which seems long, compared with placebo in diabetic patients, a group previously considered to be quote-unquote complicated. And they followed them for 2 years, which is actually pretty dope follow-up. No difference in recurrent infection, pyelo, and hospitalization. Antibiotics do not change long-term complications of bacteriuria. Even though diabetics have higher rate of development of pyelo, antibiotics do not affect that rate. This meta-analysis looked at the natural history of untreated UTI, all the placebo groups from some of those trials. A large percentage of patients, 40%, have complete resolution of their symptoms without any antibiotics after 1 week. There was no difference in the rates of pyelonephritis between placebo and antibiotic groups here either. Certainly, more patients fail to improve and need a little help. But this is generally benign, and the conclusion of the authors was that a wait-and-see strategy for patients with symptomatic UTI was warranted since many get better on their own, and waiting does not result in decompensation. This wait-and-see strategy has been experimented with in a study looking at phosphomycin versus just symptom control with ibuprofen. Phospho was better than the NSAID for reduction in symptoms, but an ibuprofen-first strategy reduced all antibiotic prescriptions, both initially and on follow-up. So it takes into consideration those failures in the non-responders. And it reduced it by 67%. About 1/3 of ibuprofen patients eventually needed antibiotics, but even 14% of the phosphomycin group needed antibiotics again. And the phospho group had more recurrences than the ibuprofen group. This jives with some of the studies that we were talking about in another video, showing that antibiotics may increase the rate of recurrent urinary tract infection by disruption of the urinary microbiome. You don't want to overtreat. Here as well, we see that the wait-and-see ibuprofen group did not have an increased rate of pyelo, and maybe this is something that you can really just see what the patient does. Okay, well, if antibiotics don't protect you against ascending infection, pyelonephritis, do they protect you against kidney injury? We see this a lot as well. My patient has AKI. I need to treat the bacteriuria. There is no current evidence that bacteriuria predisposes to any type of kidney injury, acute or chronic. I'll acknowledge that there is probably a chronic, insidious, interstitial pyelonephritis thing out there that the nephrologist will tell you that that's probably the exception to this. But this is very rare. And in studies looking at bacteriuria, even taking this into consideration, there's no difference in GFR, renal scarring, or mortality noted between groups. Well, this is a small table summarizing some of the outcome data that is proven with antibiotics. The take home here is that antibiotics reduce urinary tract symptoms. Only symptoms. Microbiologic cure is really not durable. So even though it might be a temporary metric that you could follow, why? It's really transient, and I would say it's not a hard endpoint. I don't really care about it. Bacteriuria is not harmful in and of itself. The first thing that you have to ask yourself when treating a bacteriuria is that you have to ask, what endpoint am I trying to affect? If it's reduction of symptoms, great, you've got data for that. If it's prevention of pyelonephritis or kidney injury, I'm sorry, there just isn't evidence that your intervention, antibiotics, are going to affect that outcome. That's a big reason why we don't treat asymptomatic bacteriuria. The intervention doesn't affect hard endpoints. It may even cause harm. I was taught that the treatment of bacteriuria helped prevent kidney infection, but the lie detector said that that was a lie. Antibiotics treat symptoms. That's it. There is no evidence antibiotics affect rates of pyelo, acute kidney injury, or chronic kidney disease. If someone doesn't have symptoms, you don't have an endpoint to target and are probably only hurting them. If a patient can't complain of symptoms because they are altered, how do you know that you aren't hurting them? In patients with ambiguous presentations, focusing on specific symptoms of UTI in order to determine if antibiotics is warranted is the only sound footing on the current evidence base. This was the 6th in a series of lectures that you can find at our Viper YouTube channel. Take a listen to our other 9 myths about urinary tract infection that get mistaught in medical school, and let me know if you have questions.